Can you guys see my screen okay? Yes? Okay, cool. Oh, we don't want to start with practice questions. Oops. Okay, guys, you guys have made it to the finish line here with health assessment. This is your final exam review for the ABSN. Okay, content on final exam. Now, again, I didn't get access to see the exam, so I don't know precisely all of the questions that are on there. This is all fair game that could be on there. Don't be alarmed. I know it looks like a big long list, but all of a lot of this here, a good portion of it is review, right? So review, we have ADPIE, assessment, pain, vitals, pressure, ulcers, ears, eyes, nose, mouth, throat, mouth, cardiac, peripheral vascular disease, and respiratory. New content will include abdomen, GIGU, anus, rectum, those kind of like all three tie into like one. Musculoskeletal, neuro, med math, and medication administration. Some possible questions related to lab material, which I'm pretty sure that she will have some stuff on lab material, so review your lab stuff. This might include assessment on abdomen, musculoskeletal, neuro. What are you guys saying in the chat? It's on. What's on?
We were just saying that you already started recording.
Oh, okay. Bowel.
Right, thank you.
No problem. I just want to make sure I wasn't like missing one of your questions. So bowel and urinary elimination, enemas, fecal impaction, fall risk and fall prevention, transfer and positioning, mobility and SCDs, medications. I have medications here, IVs and injections, but and I have a slide on it, but she said that apparently that's not something you guys really cover. I thought I had seen something on Canvas, so we'll kind of just glide over that, but you guys are welcome to take a screenshot of that slide just so you know what's coming up in the next class too. Okay, so let's review first. So ADPIE, you guys should be pretty well versed with ADPIE at this point. So assessment, diagnosis, planning, implementation, and evaluation. It didn't work. You're going to wash, rinse, and repeat the whole process. So order of assessment is always inspect, palpate, percuss, auscultate, except with abdomen. So abdomen, we don't want to start palpating or percussing the abdomen before we take a listen because we'll induce peristalsis. So this is the order that we use for abdomen: inspect, auscultate, percuss, and palpate. So complete versus focused assessment, we touched on this a little bit, I think last week as well, or the week before. So a complete assessment is vitals, observations, a general appearance, their behavior we look at, and we observe that. Head to toe assessment of all the structures and body systems. So it's really like a general overview of everything. A focused assessment is you're going to have your vitals, you're going to do a general survey, so you're going to like look at them and just make sure you're doing a once over. But at the same time, whatever they come in for their chief complaint, you're going to assess that specific body structure or system. So if they're having an issue that is pointing to neuro, we're going to look at mental status, level of consciousness, cranial nerves, motor system, reflexes, sensory system, coordination, station, and gait. So there will be a bunch of different things that they may test with those components looking at neuro, and they will also gather subjective. So objective and subjective data, right? You guys are super familiar, super solid on objective and subjective data at this point. Cool. Okay, vitals. So blood pressure is generally about 120/80. Do you guys know what pulse pressure is? No?
The difference between systolic and diastolic?
Oh, yeah.
Exactly. So If you have a systolic of 120 and a diastolic of 80, sorry, your pulse pressure is going to be 40, right? So you're just subtracting the diastolic from the systolic. It's the difference. So temperature, most accurate is going to be the rectal route. This is closest to core temperature. This is often used with infants because it's super important to monitor infants and especially like preemies. You want to really closely monitor their thermal regulation because they can become hypo very easily. The most common route we use to take temperature is oral. The least invasive is going to be tympanic. I'm sure you guys remember that from being in the peds office when you were a kid and having them do the temperature readings through your ear, right? And then for babies, we often use axillary. So like bigger babies, if they're doing well, we do use axillary. And then also patients who may be in a coma, we might use axillary with as well. So respirations should be between 12 and 20. When do we want to give oxygen?
When O2 saturation below 90%, 92%, and then when muscle pressure below 60 for oxygen.
So yeah, I mean, there's different numbers that you're going to hear out there. I totally agree with like, we're not going to right away throw on some oxygen if they go to like 94% or 93% even, because sometimes the O2 sat may waft, you'll see. But if they're continuously trending down, you'll know, and you'll want to get some oxygen on them. When should we humidify oxygen?
4 liters and above.
Yep, good job. Heart rate is going to be between 60 and 100. Do you guys know what a pulse deficit is? No? Okay, so a pulse deficit is going to be, there's going to be a difference between the radial pulse when you palpate that and when you auscultate the apical pulse. So we want to assess for this when we are, if we're palpating a radial pulse and we notice like some sort of irregularity with the rhythm, then we're gonna test for a pulse deficit. And again, we're gonna be palpating the radial and we're gonna be listening to the apical. If she didn't cover that with you guys, that will probably not be on there. Carotid pulse, when would we assess a carotid pulse? Think before the program. What did you guys do to prepare?
When you need to do CPR.
Yeah, so if we find a patient that's gone unresponsive, we're gonna check that carotid pulse, right? So yeah, basic life support. How would we assess for a bruit at the carotid? That says it there. So we want to have
the bell.
Yes, good job, because that is not written there, and that's what I wanted to hear from you guys. So we want to have the neck in a neutral position. We're going to ask our patients to exhale fully out and then hold their breath while we place that bell there and we listen. If they're breathing normally, then that's going to cause an interruption in sound. But if we place the bell there, they're holding their breath with it exhaled out. What would a bruit sound like?
Turbulence.
Yeah. Yep. Good job.
Would we hold it lightly or firmly? Because that was a question on the test, and I was like, I don't know.
Think about what happens when you press anything firmly over a vessel.
Yeah, that's a good point. All right.
You're going to occlude it. But yeah, the areas that you want to hold the stethoscope firmly are going to be on your lung fields and your heart fields, right? Because you're not occluding an artery there or like a vessel or anything. You want to like make sure you're optimizing your listening. Okay, so SpO2, should be 95% or above, except possibly with COPD patients, which we discussed last week. With the COPD patients, we want to make sure we get their baseline, so we can always ask them about that. Do we need an MD order for O2?
Yes.
Yes, we do. How about if you have a patient and their SpO2 is trending down, you see it trending down, they start coughing, they're having a hard time breathing. Are you gonna call that MD and be like, I need you to submit an order for oxygen?
No.
No, you're gonna get it after.
Mm-hmm.
Okay. All right, so pain. So we have chronic versus acute. Chronic is persistent and greater than 3 months. And that goes for like chronic anything. Chronic is generally like something that's longer than 3 months. Acute is short term and it dissipates after the injury heals. The types of pain we have are cutaneous, so that will be the skin, right? We have referred pain, so that's pain felt in a different area from where its origin is. So the gallbladder is a good example. You'll have right-sided shoulder pain with an issue with the gallbladder. We have visceral pain, which is often like the internal organs. So stomach, the intestines, that's going to be visceral pain. We have somatic pain, which is tissues such as ligament, joints, muscle, and bone. And then we have neuropathic pain, which is damaged nerves, and that'll feel like the pins and needles sensation. Do you guys know what that's called?
Paresthesia.
Yes, good job. Some models of evaluation for pain. You guys have been using either the PUKRSD or loud cards. Sorry guys, typo. With patients who cannot speak English or they have trouble communicating, older adults, children, we're going to use the Wong-Baker Faces Pain Scale. That's not a really good scale to use because you'll see there's like 5 different faces to choose from, and people have different perceptions of like what pain is and what their face looks like with pain. So it's not a good indicator of pain, but it's something if we cannot like get an interpreter right away. What is the best indicator of pain? It's whatever the patient says. Okay, peripheral ulcers. So they're also known as decubiti or decubitus ulcers. I don't know if you guys have heard that come up yet, but you'll hear that stage 1 decubitus in clinical, and you'll be like, what's a decubitus? It's a pressure ulcer. Impaired mobility is a predisposing factor that puts the patient at risk for a pressure ulcer. Also, being thin, frail, elderly, having incontinence and moisture is also risk factors. And then these are the stagings as reminders. I'm not going to go through all of them, you guys. This is just a review. Okay. So eyes and vision, PERLA, right? Pupils equal round, react to light and accommodation. That's testing cranial nerve 3, the oculomotor nerve. What are our pupillary fissures? I hope you guys know this because you guys have been saying it. Yeah, it's like the eye slits right here. So, or the eye openings, I should say, and they should always be symmetrical. The pupillary light reflex is looking at constriction. If one pupil, again, is non-reactive and the other one is constricting, then we're going to think a traumatic brain injury, and then there's the increasing intracranial pressure. We're going to get them head CT right away. Accommodation is that convergence and constriction. The corneal light reflex is also known as the Hirschberg test. So you guys may have gotten like jumbled and confused. They're not 2 different tests. They're the same tests. What are they looking at? or assessing for?
Strabismus.
Yes. Yep, strabismus, if anybody didn't hear that. Interpreting vision scores. So this throws people off and can be confusing. So we use the Snellen eye chart. That's the one that has like the top line, that's the big E, and then it goes down and they get smaller and smaller and smaller. And we have the patient read the smallest line that they could possibly read. 20/30 means that the patient sees at 20 feet what a person with normal vision can see at 30 feet. 20/50 means a patient sees at 20 feet what a normal person can see at 50 feet. Now it can be optimal vision. Like I haven't had my eyes tested in like 3 years, but the last I had them checked, I had 20/15. And some people can even have 20/10, which means that I can see like better than the average person. It's confusing thinking about the different terms, but know that whatever the person is seeing at 20 feet is the top number. So the numerator of that little fraction, right, is what they can see, what a normal person sees at a further distance. Okay. So ears and hearing. So conductive hearing loss versus sensorineural hearing loss. Conductive occurs when transmission of sound through the outer and or middle ear is interrupted. Do you guys know a potential example of that? Take a guess. I bet you could get it. So there's an impairment in conduction going through the ear.
Like too much wax buildup?
Yeah, cerumen buildup would definitely be an example of conductive hearing loss. Sensorineural is going to be happening over time. So it's damage over time. Whether you go to loud rock concerts all the time, you're going to be doing damage to that trochlear nerve, right? There's also just presbycusis, which you guys know what presbycusis is, right? So that's just the normal hearing loss through aging. We use the whisper test to test for these, or to test specifically for presbycusis. And this is how it's done. So you would go off to the patient's side and you'd be whispering a 2-syllable word while they'd be occluding the ear. And they have to be able to state back to you what the word was. Okay, respiratory. So normal breath sounds, we have bronchial, bronchiovesicular, and vesicular. You guys feel solid on those? No? Okay, so bronchial is louder and higher pitch. So that's going to be up here, right? You're going to hear over the manubrium, this section right here. I think they even say like tracheal and bronchial are one and the same, but then what I saw last week, there is some variation, but you'll hear it right here. And then to the side of that first and second intercostal spaces is going to be the bronchial vesicular. That's going to be intermediate in the intensity and pitch. And then the vesicular are kind of like all around, mostly the peripheral lung fields, and then a lot towards the posterior side. So you hear those a lot more on the back side. Especially hitting the lower lobes are a lot easier to hit on the backside because the lungs kind of like, if you guys think about the anatomy of the lungs, they kind of tilt towards the back, right? So you can hear those lower lobes a lot better in the back. Question?
No, I was just going to say, and I think just also knowing kind of what the word means will help us figure out sort of where the sounds can be found. So vesicular, like a vesicle.
Mm-hmm.
So the little pouches, whereas
yeah.
broncho, you had the alveoli, and the broncho meaning like the branches.
Yeah, that's exactly how I memorized it as well. Good point. Okay. abnormal breath sounds. So we have wheezes, we have crackles, we have some other ones. Wheezes and crackles are the ones that usually come up a lot. Wheezes, think asthma. Crackles, you're going to think atelectasis or heart failure, right? Because you're going to get that, or pneumonia too. You're going to get that accumulating fluid. If there's fluid in the lungs, you're going to hear crackles. What is the purpose of the incentive spirometer? It's going to help pop open those alveoli and keep them open to be doing their job. Cardiac. So JVD, we want the head of the bed at 30 to 45 degrees. We don't want a pillow behind their head because they'll be guarding and crunching like that. So take away the pillow to assess that. Have the patient turn away. You're going to shine a flashlight on the area and you're going to be looking for that distension. And it needs to be greater than 3 centimeters to be a positive finding for JVD. And again, this indicates heart failure. For auscultation, we use the mnemonic 8 to man. We're going to use the diaphragm for normal heart sounds, so S1 and S2. And those are higher pitch sounds that we always listen for with the diaphragm. So you'll also use that to listen for normal breath sounds and normal bowel sounds. We use the bell when we're listening for like abnormal things, whether that might be bruits or heart murmurs. These are going to be lower pitch sounds. So the bell really like fine tunes and like gets in there to like really listen acutely. And yeah, so it's looking for extra heart sounds, murmurs, or bruits. Skin color, we want to look at the skin color. We want to make sure that they're nice and pink. If they're not, if they're having some cyanosis, we need to assess that. Capillary refill, we need to make sure that it's less than 3 seconds. They're having good perfusion to the extremities. We want to look at if there's any edema of the extremities, and we want to see if they have any dyspnea, which again is shortness of breath. Okay, peripheral vascular. So we have signs of arterial insufficiency, which include intermittent claudication. So that's like termed like the angina of the legs. And it's commonly felt down in the calves. It's a cramp-like feeling. So it's, say you want to go out for a power walk or something, get some fresh air, and all of a sudden you're like, oh, I'm having like this awful sensation in my legs. It's like really crampy and painful, and you sit down on a bench and then it starts to go away. That's intermittent claudication. It's relieved with rest. Also with arterial insufficiency, they're going to have a lack of hair growth. They're going to have shiny skin. They're going to have thick ridge nails. They're going to have some ulceration. And these ulcers, by contrast to the venous insufficiency, are going to be like hole punch out, right? Like they're going to have like perfectly regular borders. They're going to be more on like the bottoms of the feet. The skin of the lower extremities are going to be cool. There's going to be a decreased pulse, decreased capillary refill because they're not being perfused, right? Signs of venous insufficiency. So they're going to have pain while standing in one place. Everything is pulling down in the legs. It's going to be relieved with elevation. They're going to have the irregular, sloughy wounds. They're going to, and that's going to be higher up, like on the ankles and calf areas. The lower legs, they're going to be warm to touch and flushed. So nice, they're going to have that rugor of the lower extremities. So signs of COPD, you're going to have clubbing, which is also known as the profile sign. And this is due to low oxygen saturation and decompensation. Concerns with the DP, big one. It'll cause an sequence. It is a pulmonary embolism because that DVT can dislodge and travel up through the vessels and into the lungs and cause a pulmonary embolism. So you want to immediately intervene and take care of that. We use prevention of this with SCDs, which are right here in this image. You guys will definitely see these in the hospital, especially on med-surg. So they're used as prevention for patients who are restricted to bed rest, or they're just coming out of surgery or anything like that. You're going to have the SCDs on them. We already went over complication. Okay, new material. So medication administration, so you have your 6 rights, which are right patient or person, right medication, right time, right dose, right route, right documentation. You want to always do 3 RN checks. When do we do these? Anyone?
When you're looking for more, when you're pulling the meds, and when you're at the bedside.
Okay, heard at the bedside. So you're gonna, the bedside's gonna be the last stop. First stop is right at the Pyxis, right? Right when you're pulling it, you're gonna do your check. Then right before you enter the room, you're gonna do the check. And then right when you're at the bedside, we're also gonna do your patient education. You're gonna be stating to the patient, we have, you know, some Colace for you. We're giving this to you to make sure that you have appropriate bowel movements. So Colace is a stool softener that you might see used a lot because, you know, patients coming out of surgery are at risk for constipation and all of that. So you always need to be doing patient education with whatever medication you're giving them. It's part of like their right to know what you're giving them. So yeah, good job.
I have a
Those are
question.
3 iron checks.
I have a question. If so, Dr. Botha, she really stressed her 10 rights. You think it's fair game that like those
Oh yeah,
on there? Okay.
if she stressed the 10 rights, know the 10 rights. I know that we went through the 10 rights, but the only ones that were ever tested on for us, and this was in med-surg for us. This was like the first week of med-surg because our, you know, ours is a little bit different the way our program is laid out. She only tested on the 6 rights because those are the ones that you really actively use. So honestly, like I'd have to go back and check to see what the other ones were because I can't recall them off the top of my head. But if she stressed them to you guys, know the 10 rights. That's what I'd say. Be safe. Okay, med math. So I love math. Some of you might not like math, but it's definitely going to come up a lot throughout the program. And you want to also be making sure that you're always checking your dimensional analysis with your stuff, even in clinical. Even if the computer is doing it for you, the computer makes a mistake, and it is your job to be doing the math before you hang a bag, before you give a medication. Do the math. Because I have seen a nurse make a big medication error that they could have been sued for. So it happens. And with that said, let's practice. So number 1, we have ordered 1.5 grams of acetaminophen. I have to concentrate saying that. Per oral, Q8 hours. So that's every 8 hours. We have available 325 milligrams per 5 mils. How much should be given and round to the nearest tenth? Now, that might not be indicated on the test, but always round to the nearest tenth. I'll give you guys like 1 to 2 minutes, or 2 minutes. Sorry, I don't want to like freak you out.
Just for clarification, is the question asking how much would be given per day or
No.
how much should be given per dose?
Per dose. How much should be given
Yeah.
right now? It's what you're giving to the patient now. Give it another few seconds, 10 seconds. All did great. Ones who have answered so far. Okay, you guys ready? I see the people I see are still writing, so I don't want to rush you if you're still working on it. Okay. We will reveal. So step 1, we're going to make the units the same. 1.5 grams times 1,000 equals 1,500 milligrams, right? We could do a conversion of either the 1.5 grams or the 3.25 milligrams. Just get comfortable, converting from one unit to another, and just know which way you go with the direction of the decimal, or you can just do the actual like division of it or multiplication depending on which way you're going. So I chose to use 1.5 grams and convert to milligrams. I got 1,500 milligrams. Step 2, you want to simplify the available dose concentration. So that's what's available here, the 325 mg per 5 ml. And I got 65 milligrams per 1 ml. And then step 4, you want to divide the dose ordered by the available concentration. So 1,500 milligrams divided by 65 milligrams per ml. That's our concentration, right? And I got 23 point blah, 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 blah milliliters. We want to round to the 10th place. That's supposed to say, to the nearest 10th for step 5. And I got 23.1. So those who put that, great job. I saw that one person, was thinking about, okay, how much are we going to give in 24 hours? But don't put extra information in how much should be given. That's meaning like right then. If it was asking in 24 hours period, it will say that. But you are right. I think it was Catherine or something who had written the 69 something because I checked it, and yes, that would be good. Okay, number 2, we have ordered 0.6 grams cyclovir per oral Q8 hours. We have available 200 milligrams per ml, 2 ml. How much to be given and round to the nearest 10th. Sorry for the typo there. Give it a couple minutes. Also, the whole thing that tripped up the one person that put in the whole 24-hour period was what was listed as what is ordered, but that's also always what you're going to see. When you see an order, you're going to see the full thing. You're going to see the dose and the frequency and also the route. So you'll see that in the order. You guys are doing good. Oh, Kayla, I didn't know you were in this ABSN. Is this the same Kayla Myers in CNSA? No. Yay! Hi. No worries. Okay, one more minute, guys. All right, let's get one more person to answer. Because a lot of you look like you're done. Nah. Yeah, good job. Okay, same thing again, same process. You're going to make the units the same. You're going to simplify the available dose concentration. You're going to divide the dose ordered by available concentration, and then you're going to lastly round to the nearest tenth. Now, this is my process. There are different ways of doing dimensional analysis. So if you do a different way and it works for you, that is okay. Know that. Was this helpful for you guys to review it? I just want to make sure, like, sometimes, like, my method with my math can be, like, not the most, like, popular way. So I hope it didn't, like, further confuse you and it was helpful. Okay, so this is the IV injection slide that I said that Dr. Botha said that you guys haven't really gotten to. So you guys are welcome to take a screenshot of this one just to have as a reference if you want to review it like the weekend before you start MedSurg, because it will kick off with different, like, especially the injections. It'll definitely start off with that, and then it'll carry on to IVs. For some reason, I thought you guys were doing it, so I apologize. I put it on here, but if you want to take it, go ahead. Okay, abdomen. For med terminology, wait, let me see what that says. She did? So, like, what was the question?
Yeah, what angle should you like use for? Sorry, I actually just sent that to you. So, for folks who haven't taken it, she tested us on like injections on the medical terminology 5 quiz, and it's like, you know, you need to know like, you know, like an intramuscular injection is 90 degrees, like subcutaneous is 45 to 90, like that sort of stuff.
Okay.
So she
well,
does test us.
Maybe she's just trying to, like, make sure you guys don't stress about like that, because she did email me and she said that that's not like something she's focusing on. So maybe it was just like a preliminary quiz, because are your quizzes counted towards your grades, or are they just like practice?
They count toward our grades.
Oh, okay. Well, I'm confused then. But did you grab a screenshot of it then if you want it? Are you guys good? I mean, she did say they're not going to be on the test, so I mean, don't worry about it for the test. I'm sorry that it was on a quiz, but you'll learn a lot more about those two in the next course. All right, let's move on to abdomen. Okay, so again, our order is going to be inspect, auscultate, percuss, and palpate. I'm sorry, what did the chat say? Okay, so know your anatomy of abdomen. That's usually a big one that comes up in health assessment as far as like exam questions. I recall it being an exam question for me. I mean, I like abdomen and I like GI, so it was definitely something I had solid down, but something that like it was a question that other people struggled with. And because we always went through like the percentage of like what questions were answered correctly. So know your anatomy, know which feature is in each quadrant. For bowel sounds, absent is going to be no bowel sounds. You're gonna hear 0 bowel sounds in a whole minute. Hypoactive is going to be less than 5 sounds within a minute. Hyperactive is going to be greater than 30 in 1 minute. And then normal active is between 5 and 30. Now, you're not going to sit there with your stethoscope for a whole minute counting bowel sounds. You'll just become accustomed to what normal active is, what hypoactive is, and what hyperactive is. And it might be pretty common to hear those abnormal findings too, depending on the patient's state, right? If a patient's NPO, they're getting prepped to go in for some sort of procedure, they're going to have hypoactive sounds because they're not really digesting or anything like that. So given the state, you will have a chance to hear an array of sounds and they sound like bubbles. So what is occult blood? So occult literally means hidden. It's not visibly apparent. We test this with fecal occult blood tests, which is also known as, I don't know how to say this, Guaiac test or the HEMA test. And that's just going to determine if there is blood present in the stool. Okay, so some conditions. These are acute conditions. I just put a few up here. So we have common ones. Appendicitis, which is inflammation of the appendix. They're going to have sharp pain at that McBurney's point, but it may also migrate away from that site, just so you know. It's not always just located right there. They're going to have that rebound tenderness, so you're going to push in your hand, and when you rebound, they're going to feel pain. They're going to be febrile, so they're going to have a fever. What we're going to do is we're going to give them some antibiotics and we're going to do surgery. Peritonitis is inflammation of the abdominal wall. They're going to have abdominal pain. They're also going to be febrile and have a fever because it's like infectious stuff spreading through the abdomen. They may have some vomiting. They're also going to have rebound tenderness. This may actually be a result from a burst appendix. What we're going to do is we're going to give them antibiotics. We're going to do surgery. They may need paracentesis to aspirate off the fluid. For bowel obstruction, they're going to have severe abdominal pain. I actually had a patient come into the ED when I had one of my ED days, and he was my patient that I took on, one of my patients I took on for that shift, and it was scary to see how much pain he was in. Literally, I could not get the EKGs like strips on him because he was so diaphoretic. He was so sweaty. They weren't sticking, and he was in so much pain. I pushed like one thing of morphine on him, and then we had to do another, and then finally, like that second dose of morphine, he was like finally down to like a 6 or 7 pain level. But he was like at a 10 when he came in, and he was waiting for like 2 hours out in like the triage tent area, and like just in like hunched over in a chair, like vomiting in a barf bag. Like it was awful. I felt so bad for him. So the way we're going to confirm a bowel obstruction, I knew before they sent him off to CT that it was a bowel obstruction, but we're going to confirm it for sure with a CT. We want to keep them NPO. We do not give them anything by mouth when we are suspecting that there is a bowel obstruction. They may have nausea, vomiting. So NV is nausea, vomiting. They won't be able to pass stools. So you would always ask them, when was the last time you had a bowel movement? That was like one of the main things we ask, right, with GI. And basically, yeah, this is no passing of the digested material. It's stuck. It's not moving forward. Okay. Abdomen. So these are a couple chronic conditions that I put up just to differentiate the two, because for the few of you that might know a little bit about my background, this is important for me to tell you that these are very different things. IBS and IBD are not the same thing. IBS is a food or stress intolerance. They have abdominal cramping, bloating, gas. They may have constipation or diarrhea. And this is often just, they just may have to do some lifestyle changes. There is not really any treatment that people do for IBS. IBD, by contrast, is a severe disease. It's a genetic mutation. They have an increased risk of colorectal cancer, and this is like the umbrella term for both Crohn's disease and ulcerative colitis. So looking at both conditions, they both share these. They may be on immunosuppressive therapy and or steroids. It's a serious illness that we cannot physically see or understand without actually having education on it. So a lot of people will be like, well, you don't look sick. You don't want to pass judgment on people who suffer from IBD because it's something that you cannot really be seen. So that's important to know, to just try to have some empathy for the patients. They may have blood in stool. They may defecate multiple times a day. They may have rectal pain. It's a chronic, they have chronic abdominal pain. They may have depression, risk for bowel obstruction, and they may need resection of the bowels. Those are all common things that they may need. Resection is just like taking out sections of the bowel, which can be done, but it's a procedure like anything else. There's plenty of intestine, right? You know that if you like span out the intestines, it's like a tennis court in size. But losing, sections of the bowel time and time again is not good. So GI, GU, some GI terminology to know. So paralytic ileus is a complete absence of peristaltic movement. Ascites is an abnormal accumulation of serous fluid within the peritoneal cavity. So that's basically that third spacing edema of the abdomen, right? That might happen with heart failure or a liver dysfunction, liver disease, a variety of things that ascites happens with. Hepatomegaly is the abnormal enlargement of the liver. Melena is lactary stools, and this is because there's an upper GI bleed. Cullen's sign is a bluish periumbilical color due to intra-abdominal bleeding. So it's going to be around the umbilicus area, and it'll look like a bruising, right? Hematemesis is vomiting of blood, and then emesis is vomit. Cholecystitis is inflammation of the gallbladder. All right, so GU terminology to know. Urgency is overwhelming need to use the toilet as soon as possible. By contrast, don't get it confused with frequency, which is the need to urinate more often than normal. So that's the number of times they're going. And don't get that confused also with hesitancy, which is trouble to start or maintain the flow of urine. Dribbling is the urine that remains in the urethra after voiding and it slowly leaks out. Some anal rectal conditions down here, and I put like a little animation of it up here. Hemorrhoids can be either internal, external, or prolapse. There's no hemorrhoids noted there, but anal fissures, fistulas, and abscesses People might get fissures and fistulas confused. So a fissure is literally like a groove within, it's a break within the tissue, right? Like a groove, a crevice, a fissure. A fistula is like a tunneling from one area to another, and that can also acquire abscesses in it. So you see the anal abscess here and the fistula over here. So it could be this is like an abscess with fistula. It's not the best image that I chose, but you guys understand the difference pretty much. And then lastly, we have perianal Crohn's disease, which is just like an exacerbation of Crohn's, and it affects the rectal areas, and it's very painful. Okay.
So for clarification really quick, is a fistula kind of like a mini hernia within the tissue that goes into another tissue?
It's not a hernia, because a hernia is usually something that's bulging through. It's like nothing is going into that tunneling. Does that make sense?
Yeah. It's just
Yeah.
a tunneling. Okay.
Yeah, it's a tunneling that's like going, like you can have, I was watching, what was it called, A Midwife, like a month ago, and there was like this horrible case of this woman that ended up having like a fistula between her cervix and like her bladder. She just like had no control. Like there was incontinence everywhere, and it was coming out because there was this horrible fistula that they had to go in and surgically repair. So yeah, it's a tunneling between one portion. So like you can get fistulas between, so look at the female anatomy here. Up in here is, sorry, I'm so tired. Where's the vagina? Up in here is the vagina. Okay, I was right. And then you can get a fistula that goes from the vagina to the rectum. That's horrible to think, but that's what a fistula would be. It would be a tunnel. And I was talking about a fistula. I don't know if that was another private message.
Yeah, it was good. Thank you. I got that now. Thank you.
Yeah.
I had a friend with a fistula, and I think it was like
Episiotomy.
rectal vagina, but it could have been yeah, but it was
the way it healed, probably. Yeah. So fun fact about episiotomies, they're not really routinely done anymore unless the patient asks. It's better to allow the mother to naturally tear. It heals better is what the thing is. So that is not surprising to me that happened. Unfortunate. Okay. Male genitourinary. These are important concepts to know and go through. If there was ones that she hit on more so for GU, I didn't really know what to put focus on those, but I'll go through some. So for male, you want to inspect and palpate for any swelling, nodules, lesions, discoloration, hernias, etc. If you are palpating the scrotum and you feel a hydrocele, which is basically like its edematous is swollen, you're gonna take a flashlight and shine it through. If it's illuminated and clear through the tissue, that's a hydrocele. If there is some sort of mass in there, it's going to be indicative by like a darkening shadow that the light will not pass through. And that is something that you will have to let the MD know about right away. Epididymis is a site of sperm storage. That's usually one that they like to throw in there. As also vas deferens is the muscular duct tube that leads from the epididymis to the urethra. The urethra goes from the bladder all the way down to the glands of the penis. It's much longer compared to females. It's important to know that females have a shorter urethra than males, and they have a UTI risk more than males do. I mean, of course, males have different predisposing factors that puts them at risk for UTIs, but not as much as a female. Catheters are big, though, for both you don't want an indwelling catheter in there if you don't have to have it in there. And if you have to put an indwelling catheter in, they say try to get it out by 24 hours. That might not always happen depending on the case. Benign prostatic hyperplasia is a normal enlargement of the, what am I saying? I can't even, the prostate. Sorry guys, I'm getting tired. It's a normal enlargement of the prostate, and it will cause males as they get older to have a urgency, and also their frequency will increase for urination. For females, you should know pretty well the internal and external anatomy. I mean, I would have a good idea of the anatomy of both. Have women empty their bladder before assessment and examination. It is termed delayed puberty. They have no forced development by the age of 13. That probably won't be a big one in this one because this is a PEDS course. You want to inspect the hair distribution, the skin color. You want to see if there's any lesions, discharge, or odors. The urethral opening. So I put this in here. You won't be tested on this, but it'll be a good thing to know when you go into med surg, because putting in a Foley catheter, most people think, oh, it'll be much harder through a penis, right? No, females are harder because finding the urethral opening on a female is actually pretty hard for some people. So you really kind of have to be aggressive with that tissue and manipulate it around to get that open enough to be able to see where you're going. And then there's the wink technique where you take the iodine swab and you go like this, and they say it looks like a wink. So I just want to put that in there just to prepare you guys for Foley catheters, which are super fun, and hopefully get to do one on a patient. Yeah, I already said that females have that shorter urethra, which puts them at risk for AUTI. Okay, musculoskeletal. So we have musculoskeletal and neuro. Are you guys okay, or do you feel like you need like a 5-10 minute break? Keep going? Okay. All right, so the 5 P's for musculoskeletal, we have pulses, pallor, paralysis, paresthesia, and poikilothymia. Are you guys all familiar with the 5 P's? Cool. All right, so rheumatoid arthritis versus osteoarthritis. So rheumatoid arthritis is an autoimmune disease. It is systemic. It involves bilateral joints. It's worse in the morning, and then pain improves throughout the day as they start moving. They may have low-grade fevers. Osteoarthritis, by contrast, is asymmetric joint involvement, so it's only one-sided. Their pain will get worse throughout the day the more that they use those joints. And then, do you guys know if leg length discrepancy is normal? What do you guys think? Think about symmetry with the body.
I think it's going to be a little normal, right? I mean, if the hips are kind of off, you know, an inch or so should be okay, but I think anything more than that might.
An inch is going to be
pretty crazy.
It's going to be too much.
Too much.
So
okay.
it's about 2 centimeters.
Okay.
So it is normal. The range is about 2 centimeters. But yeah, nothing with the body is perfectly symmetrical. Like people have one foot that is slightly larger than the other, right? Like nothing is perfectly symmetrical. So yeah, there is a little bit of a variation. If it goes beyond that, then you're going to start to have problems with like scoliosis. And then what is Luceau's sign? I don't know if I said that right. So it's been a long time. It's also known as the straight leg test. You guys know what that test's for?
No.
Okay, so they're going to have the patient, like they're going to test the range of motion. And then when it gets to a certain degree, I'm not quite sure what the degree that they qualify it as. If they start having like eliciting a pain response when they start bringing that leg up, that's going to be a positive sign for this. And it's looking at to see, it will be mostly indicative of like a protruding or a bulging disc of either the lower lumbar or sacral region, or it could potentially be pointing to sciatica. It's more so going to be related to the disc protrusion though. Okay, so normal full range of motion findings. I put like the more important ones that I feel like. Obviously there's neck, there's the arms, but a lot of times health assessment, I feel like if for us, she focused more on the lower extremities. So I put them here. If you guys want to take a screenshot of that, that's perfectly fine. These are all of the full range degrees of motion for each joint of the body is in your textbook as well. Active range of motion versus passive range of motion. So active is the patient performs it independently. You are not providing assistance. Their muscles are fully engaged. With passive range of motion, the patient is going to perform this with the assistance of a physical therapist or the nurse. Often that's more so done with like physical therapy. I haven't seen, or maybe even CNAs, I'm not sure. I haven't really seen my nurses that I've worked with do too much of that. It might be a specific unit too that does more of that. Okay. So these are just some more terms to know. So osteoporosis, atrophy, hypertrophy, lordosis, kyphosis, scoliosis, abduction and adduction. So adduction is adding to the body, abduction is the opposite. So add to the body, you're bringing it more midline. That's the way I remember those two. And then this is a good image of all the different spine deformities here that are listed here. You guys are good on these terms? Okay, immobility. So anytime a patient is, at risk of like their mobility being impaired or they're fully immobile, they're going to be a fall risk. We have bed alarms for these patients. These can be really frustrating, especially when you're trying to reposition a patient or you're trying to help a patient with a bedpan, and it'll start going off even if the patient is still in the bed, and you're just going to want to keep the alarm because it's loud and you can hear it all over the unit. So DVT is a huge risk with immobility, right? So we always have those sequential compression devices, the SCDs on them. We want to always make sure that we have the call light and reach for these patients if they may need help with the bathroom, with toileting or anything like that. They are at risk so much more when they are restricted to bed rest because they're immobile for skin breakdown. So you need to be routinely and frequently assessing the bony prominences, right? And doing your Braden scores. You want to make sure that you get them with rehab as soon as possible to start getting their function back. You want to always carefully, each shift of yours, like carefully assess their respiratory functions because they are at risk for atelectasis as well. Their baseline blood pressure should be checked before they attempt to ambulate for the first time because they also have a risk of orthostatic hypotension. We want to make sure that we're giving them enough fluids and maintaining their fluids, strict INOs, right? They are at risk for constipation when they're immobile. They're also at risk for urinary complications. So infections, renal calculi, which is kidney stones, And then if they're not getting that adequate fluid intake, they're going to have an issue with glomerular filtration, and their urine's going to be super concentrated. So staying on top of both urinary and GI issues when they're immobile. They're also at risk for contractures, especially coma patients. So patients who are in comas, you know, they're not moving their extremities or anything like that. So like the feet can get contractures. They have boots for these too that they may put on patients. If you see, you may have, like I had a patient who was in a coma, and she definitely had those boots on her feet, keeping them, you know, at that 90-degree angle so they weren't pushed down, because they'll get contractures if they're in that position for too long. So that's immobility. Okay, neuro. So the brain, you have the cerebral hemispheres, which is consciousness. You have the cerebellum, which coordinates all movements. You have the frontal lobe, temporal lobe, brainstem, hypothalamus, parietal lobe, occipital lobe, and cerebellum. This should be like review for you guys. So now, I feel like I'm probably taking up too much of your guys' time, so I want to pick it up. Okay, so neuro. So we want to record reflex strength. This is recorded on a 0-4 scale, and it's also looked at with musculoskeletal. That's a 0 scale with musculoskeletal. Sorry, I forgot to mention that with musculoskeletal earlier. So we do 0 to 5 as far as their strength levels, right? For neuro, we do 0 to 4 as far as their reflexes. So the plantar reflex, do you guys know what that reflex is? Yeah, so that's going to be on the bottom of the foot. Do you guys know what would be a normal finding and what would be an abnormal finding?
Is it curling of toes would be a normal finding, or am I thinking about the wrong thing?
Yeah. So curling toes response at all would be a normal finding. If the toes like fan out and they dorsiflex, like going upward like that, that's called the Babinski. The Babinski. And that's a normal finding with infants, but it disappears by age of 1. If that is something that you find in an adult patient, it's an issue. There's some sort of lesion in the brain causing that. So discriminative sensations, we have stereognosis and graphesthesia. So stereognosis is sensing or feeling a familiar object and asking the patient to state what it is. I have that pictured here. This is a common thing that's put in the hand of the patient. So we'll put like a key in the hand or some common object that patients know, and we'll ask them to identify it. Graphesthesia is we're going to draw on the palm and ask the patient to state what number or letter we drew for them. If there's an inability to do so of either of these, it's astereognosis or agraphesthesia. Okay, so Neuro Glasgow Coma Scale it ranges from 3 to 15 is what we record. It assesses eye opening, motor response, verbal response, and then anything below an 8 would be indicative of severe brain injury, and usually that is a coma. What is peripheral neuropathy?
It's damage to the nerves in the peripheral nervous system. So
yeah, so like hands and
the
feet.
hands and feet, yeah.
Yep. And then do you guys know which population is most at risk for peripheral?
Is it diabetic?
Yes. Yeah, good job. Do you guys know what the Phelan's test is and the Tinel sign? So Phelan's is the one where we ask the patient to hold their hands together like this and push them together for 60 seconds and hold it like that. If they start to feel any sort of pain, that's going to be a positive response. And then the Tinel's sign is we will percuss on the nerve root right here. If they feel any pins or needles, sensations, that paresthesias, when we do that, that's a positive sign, and they're both looking at carpal tunnel syndrome. Okay, practice questions. Okay, so patient with an open fracture of the left tibia and soft tissue damage underwent a surgical reduction and fixation of the tibia with debridement of non-viable tissue and drain replacement. When assessing the patient during the post-op period, the nurse will be most concerned about A, fever with chills and night sweats, B, light yellow drainage from the wound, C, pain on movement of the affected limb, or D, muscle spasms around the affected bone. Okay, 10 seconds, guys. This is a tricky one. Okay, it looks like people were mostly torn between A and B, and then we got a couple D's. So it's a tricky one. It's A. So that's going to be indicative of the osteomyelitis. So there's an infection and inflammation happening. The other one, so the light yellow drainage from the wound, that's going to be common after this procedure. That's why there's a drain placement there. So that's usually like, sometimes you'll see like there's a hemovac or something like that. There's different wound drainages that they use, or sometimes they'll just put Tegaderm on a site. But light yellow drainage for this type of procedure would be normal. And then the spasms, that's going to be typical as well as pain, obviously. That's like the most obvious one. Good thing no one said pain. Okay, good job, guys. Okay, so a patient with a herniated intervertebral disc undergoes a laminectomy. You guys know what a laminectomy is? Okay. And discectomy. Following the surgery, the nurse should position the patient on the side by A, elevating the head of the bed 30 degrees and having the patient extend the legs while turning to the side. B, turning the patient's head and shoulders and then the hips, keeping the patient centered in the bed. C, having the patient turn by grasping the side rails and pulling the shoulders over. Or D, placing a pillow between the patient's leg and turning the entire body as a unit. Yeah, you guys got this one. Good job. Yep, it's log rolling, right? You want to make sure we're not doing any more damage. So you got to be really careful after the laminectomy. And the best way to log roll with the lower extremity is making sure that they're being kept secure with a pillow placement between them. Okay, the nurse is percussing the 7th right intercostal space at the midclavicular line over the liver. Which sound should the nurse expect to hear? A, dullness, B, tympany, C, resonance, or D, hyperresonance? Ooh. That's a good way to put it, some people. Yeah. Most of you got it. It's that dullness. Yeah. You hear dullness when you percuss over the liver. There's also like the scratch test too. I forget what that does, but basically you'll be able to tell when you get to the border of the liver with the scratch test. Look it up. It's a good one to know. And sometimes that could be like a HESI question or something like that too. Ooh, don't look. You guys see it? Hopefully not. Okay. The nurse is aware that one change that may occur in the GI system of an aging adult is A, increased salivation, B, increased liver size, C, increased esophageal emptying, or D, decreased gastric acid secretion. If you saw it, don't answer. Yeah, usually like these questions that have to do with aging too, and the differences are good ones. Yeah, good ones that they like to put on the exams. Yeah, everything does, that's for sure. You start feeling it in your 30s. Yeah, you guys got it. Good job. Decreased gastric acid secretion is the answer, and I apologize for being click happy and revealing it. So I hope that didn't kill it for too many. Okay, the nurse is describing a scaphoid abdomen. To the horizontal plane, a scaphoid contour of the abdomen depicts a blank profile. A, flat, B, convex, C, bulging, D, concave. What do you guys think? This could be a similar one to what you might see if she covered the different, and I'm assuming she did. Most of you got this, so good job. It's going to be concave. So concave, I always think of like a cave goes in, right? I don't know, that's the way I remembered it. In scaphoid, you think of like, when you see a scaphoid abdomen, just think of like an anorexic patient, basically. Good job. Okay, during a routine physical examination to assess a male client's deep tendon reflexes, the nurse should make sure to A, use the pointed end of the reflex hammer when striking the Achilles tendon, B, support the joint where the tendon is being tested, C, tap the tendon slowly and softly, or D, hold the reflex hammer tightly. Did she go over deep tendon reflexes testing with you guys? Okay, that makes sense. This is big. So you want to think about like when you're doing like the knee, you want to just support underneath it. That way we know there's a good drop in what is being tested. So there's good gravity against the actual reflex that you're going to get. So here we'll read the rationale. To prevent the attached muscle from contracting, the nurse should support the joint where the tendon is being tested. The nurse should use the flat, not pointed end of the reflex hammer when striking the Achilles tendon. The pointed end is used to strike over small areas such as the thumb, placed over the bicep tendon. Tapping the tendon slowly and softly would provoke a deep tendon reflex response. Wouldn't provoke, sorry. The nurse should hold the reflex hammer loosely, not tightly, in between the thumb and fingers so it can swing in an arc. Does that make sense to you guys? Cool. Okay, the nurse is caring for a client with increased intracranial pressure. The nurse would know which trend in vital signs if the intracranial pressure is rising. We're almost done. So A, increasing temperature, increasing pulse, increasing respirations, and decreasing blood pressure. B, this is one that you really got to think about, okay? And we'll take time with this. B, increasing temperature, decreasing pulse, decreasing respirations, increasing blood pressure. C, decreasing temperature, increasing pulse, increasing respirations, decreasing blood pressure. D, decreasing temperature, increasing pulse, decreasing respirations, increasing blood pressure. So the intracranial pressure is increasing. Oh, who said it? Good job, Hannah. Yeah, you're going to have increasing temperature. So yes, Cushing's triad is what you want to remember. They're going to have a decreasing pulse, decreasing respiration, and the blood pressure is going to be increasing. So whoever said, I know increasing blood pressure, good job. And then the other components are just remembered with Cushing's triad. And that'll be hammered into you, don't worry. The nurse is caring for a client who begins to experience seizure activity while in bed. Which action by the nurse is contraindicated? A, loosening restrictive clothing. B, restraining the client's limbs. C, removing the pillow and raising padded side rails. Or D, positioning the client to the side if possible with the head flexed forward. Yeah, good job, guys. You don't want to restrain a client's limbs ever if they're having a seizure. You don't want to try to restrain them. You want to keep them safe. That's like the biggest priority, is that you keep them safe and prevent harm or further injury to the patient. That might be another style question that is asked on seizure activity. It'll be like one of these two that you'll see commonly asked out there, whether it's in the EAQ world or the HESI world. Good job, you guys. Okay. All right, guys. Well, it's been an honor to work with you. You guys have made me really proud. You have done wonderful. so far, and I have no doubt you're going to do awesome on the final. Let me just close out of screen sharing and we can go with questions.
Thank you.
You're welcome.